My name is Michelle Anduele, and I'm the Senior Director for Health Promotion with the Arthritis Foundation. It is my pleasure to welcome Dr. Lisa Samaritano. Dr. Samaritano is a professor of clinical medicine at Weill Cornell Medicine and serves as the director of the Rheumatology Reproductive Health Program at the Hospital for Special Surgery's Barbara Volker Center. Her clinical practice focuses on systemic lupus, antiphospholipid syndrome, and reproductive health in rheumatology patients. She led the 2020 American College of Rheumatology guideline in reproductive health for patients with rheumatic and musculoskeletal disorders. Welcome, Dr. Samaritano.
Thank you.
So, Doc, let's start talking about contraception use. As you know, family planning is such an important consideration for many rheumatology patients, but timing is very important. So what are your insights or recommendations with regard to contraceptive use when a family is not ready to add to it?
Mm-hmm. Well, you are right. It is, of course, especially important for our patients because there are times when it is not safe for someone to become pregnant, times when disease might be particularly active, or if patients are taking medications that are teratogenic, that is, that can cause birth defects in a developing fetus. So we encourage our patients to discuss contraception with their rheumatologist and not only with their OBGYN. The reason for that is that rheumatic diseases can impact which contraception is acceptable, safe, and effective for certain patients. So I can tell you that we recommend as first line something called LARC, which is long-acting reversible contraception. And that includes IUDs, whether the progesterone IUD or the copper IUD, as well as the progesterone subdermal implant, that is a little rod that is placed under the skin in the upper arm. Both of those are highly effective and very convenient. And the risk of unwanted pregnancy while using those is less than 1 in 100 at 1 year. They are safe for all of our rheumatic disease patients. Not every patient is interested in this kind of contraception, however, and so for patients who are looking for other methods, oral contraceptives are safe for some, but not all of our patients. Patients who have antiphospholipid antibodies, which are antibodies that can predispose to both blood clots and pregnancy complications, cannot take estrogen-containing contraceptives. In addition, patients with systemic lupus who have very active disease should not take estrogen. So for those patients, we can offer other options such as the progesterone-only pill. We discourage the use of condoms alone as contraception, simply because the risk of pregnancy is significant, about 1 in 5 after 1 year. And so we encourage our patients to open up a discussion with their doctor if the rheumatologist doesn't ask them, because the nature of their diagnosis, their own feelings about what contraception is appropriate for them, these are all important. We in the ACR guideline, one of our first recommendations to practicing rheumatologists was that they ask a patient of reproductive age, either at the first or at an early visit, about their family planning and about their use of contraception, because it's important to bring this up. It's an important component of women's health, and it should be addressed early. So I think that for most women, there are various options. It is known that women with chronic disorders, including rheumatology disorders, are a bit less likely to use prescription contraceptives. And that's not clear. It may be because everyone is so focused on their rheumatology disorder and addressing all of the components of that. Maybe this falls by the wayside a little bit, but that's why we really encourage rheumatologists to bring it up. And I think patients should bring it up if the rheumatologist doesn't, because it's important to have their input and, of course, the input of the OBGYN as well.
So it sounds that the family planning conversation and the contraception conversation are really integrated.
Yes, I think they should be. It's important to understand how a patient feels, what she's thinking, and what her short and long-term plans might be.
I see. So, Doc, thank you for taking us through that process and what patients should be thinking about and how to be proactive in their conversations with their physicians. So now that a woman is planning to be pregnant, what are some of the insights or strategies that you recommend to really optimize that experience?
Well, I tell my patients that when a patient with a rheumatic disease is thinking about pregnancy and family planning, there's an extra emphasis on the planning part of that. It really is important to think ahead and work with your rheumatologist. And of course, the degree of planning and the degree of change, if any, is needed, depends very much on both the underlying diagnosis and the patient's own specific situation. But for most patients, we do emphasize that it is best to plan for pregnancy during a period of time when disease is quiet or mostly quiet, minimal symptoms, and they are on pregnancy compatible medications. So because of that, it's important to think ahead so that you can put those things into place. And sometimes women with rheumatic diseases may have to wait to have a pregnancy, but waiting is worth it because it will increase the chances of having a successful pregnancy. So we look at a few things when we counsel women about preconception planning and what they can do and what the doctor can do to optimize chances for a good outcome. So it's important, as I mentioned, to have quiet disease or relatively quiet disease, because for almost every rheumatic disorder, having active disease at the time of conception gives worse outcomes for both the mother and for the pregnancy outcome itself. Another important but rare situation is where a woman may have severe damage from prior active disease, such as kidney failure or pulmonary hypertension. Although it's not common, there are certain situations where patients really face very high risk if they were to become pregnant. And so for those patients, depending on their situation, and the situation is often complex, but sometimes they can turn to surrogacy and do IVF and have a gestational carrier. Once we know that disease is quiet, we plan on the right medications. And fortunately, there are a number of medications that can safely be taken during pregnancy. Not all, though. And so common medications like methotrexate or mycophenolate, those are not safe to take during pregnancy. So we need to adjust the medicines ahead of time and then watch the patient and make sure that things are stable for several months before actually then planning to conceive. We don't want to change a medicine, have someone get pregnant and then have a big flare because that medicine isn't working for them. And then the last thing that we look at are other factors like the presence of certain autoantibodies, antiphospholipid antibodies that I mentioned in reference to contraception are important to know about for pregnancy. They can occur in patients who only have those antibodies. They're present in about a third of patients with systemic lupus, far less common in other underlying rheumatic diseases, but they're important to be aware of because it may change our monitoring or even our medical management. Other antibodies that are important include anti-Rho-and-La or SSA and SSB antibodies. Those can cause inflammation in the developing fetus. And although serious and long-lasting changes are rare, it is important for us to know if a woman has those antibodies so we can do appropriate monitoring. And then finally, for patients who've had surgeries, total hip replacements, things like that, we need to make sure that joint range of motion is okay for eventual vaginal delivery, things of that nature. Those are just important to be aware of ahead of time. Finally, depending on one's diagnosis, the likelihood of having a flare either during pregnancy or after pregnancy varies, but it may be higher than it would otherwise be if the patient weren't pregnant. So it's important to have a plan in place. The patient should know and the doctor should know what they will do if a flare occurs during the pregnancy or in the postpartum period. What meds will we add? What will we change? Because we don't want to be taken by surprise. And there are certain situations, rheumatoid arthritis, for example, has a high rate of remission during pregnancy. Up to 50% of women will go into a remission and can discontinue their medications. But almost all of those women will have a flare afterwards, sometime in the postpartum period. So it's important to be aware of that. Obviously, having a flare when you have a newborn infant and perhaps are trying to breastfeed and care for that infant, that can really impact your ability to do that. And so we like to have a plan in place.
Dr. Samaritano, are there any age-specific considerations? So for someone in their 20s versus their 30s or early 40s who may be considering getting pregnant?
Yeah, I think that for our disorders, age plays into it only in that we sometimes tell our patients with very active or severe flares, of course, now is not a good time to get pregnant. And so it can take a while until a patient gets to a point where she can consider pregnancy. And at that point, she will be older. And if she's in her 30s, maybe she'll be 40. And that is the way that our diseases, I think, impact or interact with age. There aren't specific recommendations or differences in terms of your risk from your rheumatology disorder during pregnancy that relate to your age. The concern about age is that the older one gets, the more difficulty there may be in the late 30s and early 40s in conceiving, and some complications of pregnancy, risks of those increase as well. But that's really related to the age itself. And so it's not directly related to underlying autoimmune disease, but it could, of course, combine with risk from autoimmune disease and might make a woman's risk that much greater.
So you mentioned expecting or planning for a flare after pregnancy. What considerations around breastfeeding should women be aware of?
Well, fortunately, many of our medications can be taken during breastfeeding, and that includes a spectrum of medications from azathioprine, for example, which is one of our classic immunosuppressive meds, to the newer biologic medications. Biologic medications are immunoglobulins. They're antibodies manufactured in the lab. And because of that, they are a large size and they do not generally pass into breast milk. So almost all of our biologic meds do not get into breast milk and are not transferred to the fetus. So that gives us a lot of flexibility in terms of which of those medications we can use. We still cannot use methotrexate or mycophenolate, which we use commonly, but we can use azathioprine instead of mycophenolate. Perhaps we would use a TNF inhibitor or another biologic instead of methotrexate. So I think for most women, they are able to breastfeed if that is what they would like to do. It's unusual for the medications to limit a woman's ability to breastfeed, unless, of course, there's a flare and you do need to turn to one of those other medicines that, are not safe. In terms of planning for a postpartum flare, I think that it is important to be aware of it. And then the patient and the doctor can work out what they think is the best approach for that person. So I've had some patients who say, I do not want to go back on my medicine unless I know I need it. And so they will wait. And when they invariably get symptoms of their RA, we'll start them back on their medication. Then there are other patients, though, who have had such serious inflammation that they are concerned, and I would be concerned about keeping them off medication any longer, than we have to. And so in that setting, sometimes we'll resume their medications after they deliver, hoping that that postpartum flare won't happen. So that is, probably most common, I would say, in rheumatoid arthritis and some of the other types of inflammatory arthritis that are RA-like in their clinical presentation. It does happen with lupus as well, although it's a bit less common. For lupus, it's more that the risk of flare is present during the pregnancy and also after the pregnancy. And so, again, having a plan in place is important. If we have to, we can use corticosteroids like prednisone during breastfeeding. So, and as long as the dose is under 20 milligrams, we don't even interrupt the breastfeeding. If the dose is over that, we just ask the mother to not breastfeed for 4 hours after the dose. So very little is transmitted to the infant. And yet, of course, for acute treatment, not long-term, but an acute flare, that can be very useful. And that's a good option.
Okay. Dr. Samaritano, as we close, do you have any kind of words of encouragement for rheumatology patients? I know many may be watching who are at different stages of this process, or maybe having to wait longer than they'd like to, maybe having some frustrations with regard to disease activity and flare. Any words of encouragement for them?
Yes, I think that overall, most of our patients can and will have successful pregnancies, but it does take planning and it takes patience. But you just need to, just as you know, women with rheumatic diseases, I think, learn patience, right? We start them on medications and tell them this won't work for 3 months, but when it works, it will really help you. It's that same mindset, just to understand that while it may take you more time than it takes your friend or your neighbor, it most likely will happen. And the other important thing is that we know so much more now about the use of medications, the safe use of medications during pregnancy and breastfeeding, the appropriate forms of contraception. We know better how to monitor patients, and we know better how to counsel patients so they have an idea of what to expect, because that's important. It's very important that you know what lies ahead and whether your pregnancy is the same as the general population in terms of risk, or whether it really is a higher risk pregnancy, and then what we will do about that to monitor more carefully or treat with something additionally. So I think that the message overall is encouraging. We know more, and as long as women can work with their rheumatologist and their OBGYN, I think ultimately they're likely to be successful.
Okay. Dr. Samaritano, thank you so much for your time.
Thanks. It's a pleasure being here.